Good afternoon, everyone. So this is the case that I finished up with that, you will see at the end, but 6-year-old female presents with severe low back pain with some leg pain. Again, very similar picture that Ed showed, L4-2S1 instrumentation and fusion. Now presents with adjacent level disease, but this lady is pretty sick. She has a bunch of comorbidities, significant cardiac history. So my workup was that I wanted to, effectively give her some quality of life, but also at the same time be safe in the OR for her. Didn't really want to keep her in the operating room for so long. So I decided to do a lateral standalone on her. This is another company that I decided to use. Initially, I used one plate hole, but I was worried about my ALL integrity. So I decided to put a 2-plate hole lateral plate on it. So far, she's doing pretty good. She has maintained that initial height. So my worrisome that was, that I have ruptured that ALL. I'm still watching her. I don't think so, but this is something over time will tell me. So far she's doing pretty good. I was able to get her off the table pretty quick. The best advantage of this lateral lumbar inner body fusion is the time that we spend in the OR. A lot of time we spent, looking at the X-ray, looking at the MRI to preparing for it. But as soon as the cases start, it's a 30 minutes procedure. You will be in and out of the surgery pretty quick. We even looked at our data to see how safe and effective these standalone laterals are. We published it a couple of years ago. We had about 44 cases with adjacent level disease that underwent standalone lateral, either with a plate or without a plate. We followed them for about 1 year, and that was the limitation of this paper, that they didn't have a longer follow-up back then. And when we look at our data about the leg pain, back pain, and their ODI, their number have significantly improved, and we had minimal subsidence even with this titanium cages. So that's my case.
Puya, I don't see any questions in the chat. How do you manage patients in this scenario when they have osteoporosis, or, is there a cutoff in a T-score, or how do you decide whether they're a good candidate for a standalone?
So, that's a great point. The cutoff is T-score of -1.9. If the numbers are smaller and they're osteoporotic, they will be going on some sort of anabolic agent for at least 3 months before they get the surgery. The fact that, this lateral cages span from one epiphyseal ring to another, and they're sitting on the cortical rim, if, the procedure is done safely and, the surgeon is careful about the end plate and they don't violate those end plate, I think the rate of subsidence should be smaller than a regular open cases when you do smaller like T-leaf cages. These cages act as a snowshoe, so they're sitting on the epiphyseal ring. So not only they decrease the subsidence rate, but they also increase your fusion rate. So, but I would be very, very cautious with somebody who has osteoporotic bone.
So T -1.9 or worse, you'll put them on an anabolic.
Yes, for 3 months.
And 3 months, do you check another DEXA, or you just go ahead and go to work?
Well, unfortunately, the insurance doesn't approve their bone density. Depending on their symptoms, if they're absolutely miserable, I would just go ahead and do it.
Yeah. Thank you.
Puya, you've done a lot of research on this. In your cohorts, have you seen any in patients who may fail, and hopefully you don't have many, but how are they failing, and is there any role that you would see an advantage in using this contralateral fixation of the staple to decrease failures or improve the stability and make a clinical benefit?
I think, if there is, a question of ALL disruption, which can happen, especially if you're too anterior, you need to back them up. So the fact of having the contralateral staple adds another point of fixation to your construct. If there is an spondylolisthesis and there's a dynamic flexion extension that shows this is a mobile spondy, then I will back them up. So in that case, having a lateral or a contralateral staples is a benefit. I have yet to use this device on a case, but I have used it multiple times on a cadaver. When you close at the staples, it really brings the lateral plate and the staples to hugging the vertebral body. So it's like locking those two vertebral bodies together. Biomechanically, I don't know how strong it is, so that's something that should be studied. But I think it will add a significant amount of strength to your construct.
Well, that's something we're studying right now.
Very good, perfect.
I also say this, the lateral for the adjacent segment disease. I think one of the sweet points for it is that we with posterior constructs we often don't get as much lordosis as we hope, and sometimes it's our saving grace to try to add that little bit of lordosis, particularly for 4-5 and 3-4.